All right, everyone, we are going to dig through the endocrine system a little bit here. We're going to talk about three major parts of the endocrine system: the pituitary gland, review the thyroid gland. I think a lot of you had that in block 2, and add on the parathyroid gland in case you haven't discussed it already. And then we're going to be talking about the adrenal gland. So let's start with an overall view of the major endocrine glands. Again, we're really going to be discussing the pituitary, the thyroid, and the adrenal gland at this point. We've discussed the pancreas last unit, and we're going to be talking about the men's and women's hormone in the men's and women's units. And the thymus gland, we'll talk about that, has a role in our immunology, so we'll talk about that in hematology. So for this session, we're going to first start with the pituitary gland. Pituitary gland is in the brain, and it kind of hangs towards the front of the brain. You can get to it from going directly up through the nose, and it's kind of hanging right in the front area of the brain, front underside side of the brain there. Anyway, it's two separate glands called an anterior and posterior pituitary, and you can see they have a whole lot of roles. So what we're going to do is we're going to talk about the posterior pituitary first, and we're going to talk about the role of antidiuretic hormone. I'm going to leave oxytocin, prolactin, and all the reproductive hormones. Hopefully you got those in maternity, but we're really going to focus on the antidiuretic hormone, and then we are going to focus a little bit on the anterior pituitary and its role in stimulating some of our other glands. So let's take the posterior pituitary first, and we're going to talk about its job. Its main job, other than, like I said, reproductive enzymes, is going to be antidiuretic hormone. Remember, in the renal lecture, we talked about how the brain controls antidiuretic hormone, and this is where that control exhibits. So we're going to talk about disorders of antidiuretic hormone. The brain is supposed to sense the fluid levels and send out a message to the kidneys on whether it needs more or less fluid, and the kidney will pee or not pee depending on what the brain tells it to do. And that is antidiuretic hormone. So when the brain sends out a lot of antidiuretic hormone, the kidney is told don't pee. And when it's not sending out a lot of antidiuretic hormone, it's being allowed to pee. So the kidney won't be peeing unless it's told not to by the brain. So when we talk about diabetes insipidus, we are talking about a disorder of the pituitary, and it is a decreased production of antidiuretic hormone. So the don't pee hormone is not being produced by the brain. And this is an inappropriate. This is appropriate would be to produce it or not produce it based on your volume level. Inappropriate lack of production means that you're not telling the kidney to not pee. The kidney is just peeing and peeing and peeing. It's not getting its feedback, and it's inappropriately peeing and peeing and peeing. It makes the patient dehydrated. So I like to call diabetes insipidus DI, and I like to call it DI dry, because it's a rhyme, makes sense, but it also means that you have a dry body. And the reason you have a dry body is because you are peeing too much. It has nothing, and I'm going to repeat this again, it has nothing to do with diabetes. The reason it's called diabetes insipidus is because it mimics the symptoms of uncontrolled diabetes or diabetic ketoacidosis. It mimics the symptoms of polyuria, a lot of urine. It mimics the symptom of dehydration and thirst, but that is all it has to do with diabetes. It just has similar symptoms. So it is horribly named. It is not diabetic. It's not caused by the pancreas. It's not caused by insulin. It just shares some symptoms with diabetes, and that would be polyuria and dehydration and thirst. So this is based on bad production of antidiuretic hormone, and the body is allowed to pee unfettered. So you have huge amounts of urine output 4 to up to 24 liters a day. That's a liter an hour. This is a lot of urine. The urine that comes out is diluted, very, very diluted. That means it has a low osmolality, low specific gravity. It is not full of concentrates. It's all water. So very clear, pale, diluted urine. Because you are peeing and peeing and peeing so much water, you are internally dehydrated, thirsty, weight loss, decreased blood pressure, orthostatic heart rate, orthostatic blood pressures, dry mucous membranes. But our regulation for that is supposed to be the brain telling the kidney, hey, you're letting out too much, stop peeing, but it is not letting this hormone go. So a lack of antidiuretic hormone. If this is allowed to continue, the patient could become so hypertensive that they're severely dehydrated to the point of brain dehydration, and you can have renal failure due to pre-renal cause of severe dehydration. So what do we do if the brain is not producing antidiuretic hormone? Something happened to the pituitary, it's not producing, it's not sensing water levels, it's not telling the kidney to stop peeing. We're going to monitor this, and we're mostly monitoring for improvement. Of course, because it affects urine output, we're going to be watching the urine output, urine osmolality, watching the weight, blood pressure, heart rate, mucous membranes, and electrolytes. When we're treated, which I will tell you the treatments, the urine output should decrease. Remember, this is inappropriate urine output, a leaky bucket. We need to plug the hole. It's peeing too much. So when we do give treatment, the urine out should decrease. The urine should become more concentrated, but we're going to keep it in a balance. We want it to decrease, but we want it to stay normal, not go to oliguria or no urine output. We want the urine output to decrease but stay adequate. The urine osmolality will increase or become more concentrated but not too concentrated. Our weight will increase, but we're not going to become fluid overloaded. We're just doing a balance here. We're going to plug the holes, but we don't want to plug all the abilities to get rid of urine. So what we're going to do is we're going to give the hormone. We're going to give antidiuretic hormone, and that is DDAVP. It is synthetic antidiuretic hormone. It's called desmopressin or DDAVP. There's multiple ways to give it. It can be given IV, nasally, PO, sub-Q. And the dose is, you're going to be watching the dose when they first start taking desmopressin or DDAVP. They'll start it with a recommended dose per kilo. But if the dose is not effective, so we're going to give antidiuretic hormone. We're going to make the kidney stop peeing. The brain's not doing the job, so we're going to do the job. We're going to replace antidiuretic hormone. If we give too little, too small of a dose, the symptoms of DI won't resolve or could return because you're not giving enough antidiuretic hormone. So the urine still spills out. If you give too much of a dose of antidiuretic hormone, the patient could stop peeing almost entirely and become oliguric and fluid overloaded. Again, this is due to our replacement of the hormone, so we are going to be evaluating the treatment based on whether they are peeing adequately, gaining weight, retaining urine, retaining fluid, because they were dehydrated. We want them to hold on to some of that fluid. We're telling the kidney to stop peeing, but not completely. Stop peeing out so much. We need to watch that dose, and it could go seesaw the other way. If you give them a large dose of DDAVP and they go oliguric and start gaining weight and start becoming fluid overloaded, the dose needs to be adjusted. So we will give the antidiuretic hormone because we are lacking it, and they will give IV fluids to treat the dehydration, strict I's and O's, mostly to watch for urine output and make sure it is adequate. So we want to see the patient become less dehydrated by holding on to fluid but not holding on to too much fluid. So DI, very simple, not enough antidiuretic hormone being released from the brain, and we need to give antidiuretic hormone. We need to give the right amount, and we do need to monitor our quiescence before and after we give DDAVP to make sure that the urine output is going the way we want it. So DI, caused by lack of antidiuretic hormone, causes a very dry body. You've peed out all your urine. So you're going to have to replace some fluid and tell the kidney to stop peeing by giving a DDAVP. The causes of it are usually something happening in the brain that would affect the pituitary gland, stroke, head trauma, surgery, brain tumors. And if the patient has a lack of antidiuretic hormone secretion, they'll take their vasopressin daily as prescribed. And either you or the patient, when they go home, will need to monitor their urine output and notify the provider if the output is more than fluid intake, because now it's starting to pee too much, or less than an adequate amount, it's starting to hold on to too much fluid. The vasopressin dose might need to be adjusted. And we don't want the patient diuresing from other causes, such as foods and caffeines and drinks. We're going to make sure that they are staying adequately hydrated and that their vasopressin dose is effective. Sometimes when brain trauma resolves, the DI will resolve as well, and they will start putting out, they'll start concentrating their own urine, and we can reduce the dose of vasopressin. If it's a tumor or the pituitary has been removed, it will be lifetime. So take the vasopressin daily as prescribed, monitor urine output very, very closely, because if for some reason the pituitary starts to reproduce its hormone, then we're going to have to adjust the dose of vasopressin. So monitoring the urine output, there is no set perfect amount. We just want it to be adequate. We don't want it to be too little, not too much. We want it to be adequate. So that is DI, dry body. Replace the fluid, give them their antidiuretic hormone. SIADH is syndrome of inappropriate ADH secretion. I like to call it SI soggy. So we have DI dry and SI soggy, and that is our body is fluid overloaded. This is because the posterior pituitary is releasing too much antidiuretic hormone, too much hormone saying don't pee. So the kidneys don't pee, meaning you get low urine output and concentrated urine, not because there's anything wrong with the kidney, but because the brain is telling, it's just doing what it's being told to do. So of course they're probably going to check when you get an oliguric patient with low urine output and concentrated urine. They'll check the kidney numbers, and the BUN and the creatinine are okay. And they have to start looking for another cause, and the other cause could be too much antidiuretic hormone. You have fluid excess in the body because the kidney is not peeing out water, so the body is full of water. Serum blood osmolality are low, meaning the blood is diluted with all this water. Weight is increased, blood pressure is increased, heart rate is increased because it's circulating too much fluid. So it looks very much like fluid overload due to renal failure, but it is not due to renal failure. It's due to too much antidiuretic hormone. Worsening edema could be pulmonary edema. Probably we could put in there pitting edema, but pulmonary edema is what we really worry about, and cerebral edema. Getting that edema into those the lungs and the brain would be worsening cues of SIADH. So what do we do when the brain is telling the kidney not to pee and we don't want it to do that anymore? We have to override. The brain is putting out too much antidiuretic hormone. The posterior pituitary is putting too much antidiuretic hormone. We have to override that hormone. And of course, we're going to be continuing to monitor our lung sounds, our urine output, urine osmolality, because again, this is how we're going to tell that our treatments are effective. We're going to override the hormone from the pituitary with diuretics. So the brain is telling the kidney to not pee, and the kidney's just doing what it's told. We're going to override that signal with a diuretic. They're going to be high-dose diuretics, and you are going to watch your assessments for treatment effectiveness. So just because your patient starts to pee more, you're going to be giving them high-dose diuretics to get rid of the fluid overload. A normal dose of Lasix probably won't override the brain signal of antidiuretic hormones. So probably high doses of Lasix to get the kidney to pee. And so just because the patient is putting out urine does not mean that the Lasix dose is effective. You're going to have to watch their fluid overload symptoms to see if they're improving. So if you have crackles and edema, you're going to give Lasix. And just because they have increased urine output, that doesn't really mean that you fixed the problem. You have to listen to the lung sounds to see if you fixed the problem. If you have crackles, edema, confusion, pitting edema, you have not fixed the problem until those go away. Your dose might not be high enough of Lasix. So keep an eye when you give your diuretic. Say the doctor orders 80 milligrams of Lasix. They may increase their urine output. Their urine output's gone from 100 an hour to 200 an hour. That means the Lasix is working, but is it working enough? Has it cleared your lungs? Has it cleared your edema? Has it cleared your confusion? If it has not, the dose might need to be higher. So remember, just because you put more urine out after Lasix, it doesn't mean it is effective. Look at your lung sounds, look at your confusion, look at your pitting edema to see if Lasix is making a difference. If the dose is not enough, the symptoms of fluid overload don't improve. If the dose is too high, the patient can become dehydrated. So again, just because you're ordered a dose of Lasix doesn't mean it's automatically right. You have to double check your patient to make sure that the treatment is being effective. The other thing they will do after you give the diuretic is a hypertonic solution, thick, and what they will do is hypertonic saline. And that thick, so you're basically putting a lot of salt into your bloodstream, and what that's going to do is attract fluid from the tissues into the bloodstream. So what we're doing is we're doing a wringing and squeezing. So if I draw a picture of a blood vessel here that is completely full of fluid, this is an SI soggy patient. We're going to say they have a ton of fluid to the point that it's bulging this wall and making our blood pressure go up, and it is leaking out into the tissues. This is massive, massive fluid overload. Okay? We've got fluid in the tissues, and if those tissues are the lungs or our brain, that's a bad sign. But we've got fluid in our tissues, and then what we're going to do is we're going to give Lasix. And when we give Lasix, we are going to see, we're going to still have, I guess I'm going to have to draw here. I'm going to have to use my eraser. When we give Lasix, what we are doing, so here's the fluid in our tissues, and there's the fluid in our vessels. When we give Lasix, we're emptying out the blood vessels a little bit. So now we have just a little bit of fluid in there. Then that will stop this removal. Like all of a sudden, now the blood vessels have just enough fluid in them. They're quite content. They don't need to do anything else. The blood vessels are like, hey, this is a great pressure. I'm not bulging anymore. I'm not losing a lot of fluid. We can live like this. So the blood vessels are quite happy. But look at all the tissues out there. Blood vessels are happy now, but these tissues are full of fluid. We stopped the exodus from the blood vessels to the tissue, but how are we going to get fluid out of there? The diuretic just emptied those blood vessels enough to make it tolerable living environment. Then what we're going to do is we're going to put some salt in there. We're going to put some hypertonic saline, and now the fluid is massively attracted to that saline and starts going to dilute that saline. And then what we have is we have fluid out of the tissues. So let me draw. After we do the system, we did the diuretics, which emptied out the vessel. We gave the hypertonic saline. And so let's redraw our system here after we've done our two interventions. We have still some fluid in the tissues, but a lot less. And now we have, because we had the hypertonic saline, now we're all bulged up again. Because with that hypertonic saline, we've attracted fluid from the tissues into there, and now we've filled up those tissues again. And so we give another dose of Lasix, which now clears out our vessels, wrings out the vessels, and then we put in some more hypertonic saline. And so the hypertonic saline is running kind of continuously, but what it's doing is it's acting like a sponge. And now we're going to pull the rest of the fluid from the tissues, and we eventually end up drying out the tissues. So the tissues get all nice dried out, your blood vessels get filled, and that's the point when we have to stop the hypertonic saline. You have to stop the hypertonic saline once the tissues dry out. So you have to be watching that, because if we dry out the tissues and continue to give hypertonic saline, then we will cause dehydration of the tissues. So you can imagine that we're going to be watching this patient closely, and we're going to be giving them constant hypertonic saline and every 4 or 6 hours diuretics, and we're going to be squeezing that vessel. We're going to be emptying the vessels, pulling fluid from the tissues, emptying the vessels, pulling fluid from the tissues, emptying the vessels, we're basically wringing out the tissues is what we're doing. And as soon as those tissues start to get dried out, so the pitting edema goes away, your lung sounds clear up, the tissues don't have fluid in them anymore, that's when the hypertonic saline has to stop, because we don't want to continue that. We're just doing that to wring it out, and that's when we could probably reassess our situation and see what's going on. So the loop diuretics and the hypertonic saline are basically a way to sponge out the tissues, and they are so full, the tissues are so full that we need to do something just other than just Lasix. We want to put in that hypertonic saline to really physically suck the fluid in from the tissues, and then we give a dose of diuretic and empty out the blood vessels and make more room to suck more fluid out of the tissues. But we will do this until the patient stabilizes. So we're going to be watching this patient very, very closely, and it's important to restrict their fluid and make sure that we're just doing the Lasix and the 3% until everything is stabilized. If they start having dry mucous membranes or increased thirst, we'll have to adjust our dosage, stop the hypertonic saline, and this will be closely monitored with lab work and your assessment to figure out when we have fixed the SI issue. The underlying causes are harder to fix, but you will be treating underlying causes in the meantime. So what started this pituitary from secreting too much in the first place? Interestingly, one of the big causes of it are lung cancers or severe lung infections. Lung tissue can produce what is similar to ADH. So sometimes it's the first sign of a lung cancer is getting this SIADH. Lung cancers or severe lung infections can secrete an antidiuretic hormone from the lung tissue. So lung cancer is a big cause of SIADH. Of course, that would be quite a bit of an underlying treatment to fix, but finding a lung cancer would be an explanation for having SIADH. The rest of them are neurological. Again, anything that damages the brain or nerve conduction from the brain. Remember, the pituitary is supposed to be sensing our volume level and then sending antidiuretic hormone out. Sometimes when the signals, again, all of our brain communication is electrical. All the nerves are fired by electrical firing. When we have disorders like stroke, trauma, meningitis, abscesses, psych medications, they disrupt the communication to the pituitary gland, and the brain might not sense, or maybe it does sense that it's getting full, but it doesn't have the ability to send those signals to the pituitary to release stop releasing, the antidiuretic hormone. So the pituitary misfires and sends out too much antidiuretic hormone. So really neuro cases, just like with DI, brain trauma, stroke, meningitis, any neurological disorder could predispose you to DI or SIADH, depending on how the pituitary reacts. But SIADH does also have a lung cancer component to it. So getting rid of the underlying causes can resolve the problem. In the meantime, you have to deal with the symptom treatment of fluid overload. So that is the basis of SIADH and DI. I know that's a lot, so think of yourself as, when you're looking at DI, think of a dry body. That is a dehydrated patient, and the reason they're dehydrated is too much urine output. And SIADH is soggy body because you are putting out too much antidiuretic hormone and you are not peeing. So DI, too much pee, dry body. SIADH, not enough pee, wet body. No problems with the kidney. BUN and creatinine are perfectly fine on both of those. So that is DI and SIADH. Other pituitary disorders coming from the anterior pituitary, the front of the pituitary gland. We will talk a little bit about Cushing's and Addison's when we talk about adrenal gland, but the pituitary does make adrenocorticotropic hormone, ACTH, and that stimulates the adrenal gland. So we can have disorders of an adrenal gland secretion when we have too much stimulation of that. And the anterior pituitary stimulates thyroid stimulating hormone or thyroid secretion. So we can have issues with our thyroid gland due to pituitary involvement as well. So we will talk about those when we talk about our separate areas. The last thing that the anterior pituitary does besides reproduction hormones is growth hormone. And so we'll kind of just put those in there. I'm not going to really talk about them. Disorders of growth hormone, if you have too much, you have gigantism, overactive growth. If you have less, decreased production of growth hormone, you end up with dwarfism and, dwarfism. And then oxytocin, prolactin, FSH, LH are all parts of the reproductive system hormones and are controlled from the anterior and posterior pituitary. But we're not going to be discussing those. I really want you to focus on SIADH and DI, which are antidiuretic hormones, and then we're going to talk about thyroid and adrenal gland, and we have stimulating hormones coming from the pituitary. So let's go down to the thyroid gland. And I think you covered thyroid gland in Block 2, so some of this will be a review. For those of you who are not in Block 2, this is your review. Hypothyroid just means that you are not producing enough thyroid hormone. There can be many reasons for that. You can have an inappropriately acting thyroid gland, or you can have an inappropriately acting pituitary gland. Both of them could cause hypo or hyperthyroid. So if you're hypothyroid, everything slows down. Your thyroid is involved in your metabolism, and when you are hypothyroid, your metabolism slows down. Heart rate slows down, blood pressure is a little bit lower, not too low, just on the low end and normal. Fatigue, confusion, depression, impaired memory, everything's kind of sluggish. Temperature is lower than normal. Again, this is your metabolism. Everything is sluggish. Bowel sounds sluggish, increased risk of constipation. And when you look at your lab work, basically the T3 and T4 are low. What thyroid does is it makes T4, and then iodine is used to turn it into functioning T3. So your T3 and T4 levels are low. The T4 because the thyroid's not making it, and T3 because it can't be converted from T4 to T3. So both of those levels are low, and there are two causes. Either the thyroid stimulating hormone could be low if the pituitary is just not putting out anything to stimulate the thyroid. So if you have T3 and T4 levels low and a thyroid stimulating hormone low, then the cause is pituitary. If you have a T3 and T4 level low and your thyroid stimulating hormone is elevated, that is that is not caused by the pituitary, it's caused by the actual thyroid gland. The pituitary is trying to stimulate the thyroid gland and it's not working. So huge amounts of thyroid stimulating hormone are being produced by the pituitary, but the thyroid's not listening and it's not producing T4, which doesn't get diverted to T3. Cholesterol level can also be increased in hypothyroid. So really the only way we can determine the cause is looking at the thyroid stimulating hormone. And if it is low, the pituitary is it caused. And if it is high, the thyroid itself is the cause. The worsening cues of this is untreated hypothyroid, and then adding this person who's already at a hypothyroid level to infection, illness, or stress, along with untreated hypothyroidism, can cause myxedema coma, where everything slows down to a almost comatose state. The heart rate becomes not just the low end of normal, but now bradycardic. The blood pressure is not just the low end of normal, but is now hypotensive. The patient not just confused or depressed, but now unresponsive. Severe hypothermia, hypoglycemia, and decreased respirations. Again, this is usually only untreated hypothyroidism that is affected, that is exacerbated by illness, infection, or stress. This actually did happen to me with my fourth pregnancy. I had pregnancy-induced hypothyroidism or thyroidosis, where I guess my immune system got a little bit nuts during pregnancy and attacked my thyroid, and the thyroid stopped producing T4. TSH was super elevated. It was the actual thyroid gland could not produce T4 anymore because it had been autoimmune disrupted by the pregnancy. And then the stress of the pregnancy caused things to go a little haywire. So I went in for a visit. I had been super tired, super tired, and was chilled and cold all the time. My hands and my feet were freezing, had a hard time catching my breath. And when they went in, they diagnosed myxedema coma. Now, it was not a coma. It was early signs of it, but I had bradycardia and decreased respirations, and my blood sugar, I think, was like in the 50s, and then super fatigued. So the treatment for hypothyroid or myxedema coma, if you are starting to develop it, is taking your thyroid, taking the hormone. You're missing the hormone. You're missing the T4, which turns into T3. So they give you T4. Basically, levothyroxine is T4. It's just replacing what is not being made by the thyroid gland. And you can give levothyroxine IV or PO, and the dose will be modulated by lab work. So T3, T4 levels, thyroid stimulating hormone levels, and you'll be getting checked if you are taking levothyroxine every few months until they get the level adequate. And then you'll be checked every 6 months to a year. And then I've had plenty of friends who have had issues, and when you go in for a lab check, all of a sudden your T4 level is high, and they can reduce the dose of levothyroxine. It really depends on your lab levels, what they're going to do with the dosing of levothyroxine. But how do we know it's working? The key assessments start getting better. Your temperature goes back to normothermic. For a long time, my temperature wasn't getting above 37. It was like 36.6, 36.4. I didn't have a normal temperature until I got my thyroid levels under control. So anyway, your temperature will become back into control. It will relieve some neurologic depression, sluggishness, constipation should resolve. Everything should come back to the normal range on an adequate dose. You can go too far the other way, though, and have hyperthyroid. Oh, and proper administration of levothyroxine, empty stomach first thing in the morning, and it does not get along with DIG or anticoagulants. Hyperthyroid, the other way around, is too much T4 being produced. So we have high T3 and T4 levels. Again, we really have to look at the thyroid stimulating hormone to see if it is a pituitary cause or an overproductive thyroid. The hyperthyroid makes everything kind of hypermetabolism. If the hypothyroid slowed down your heart rate, hyperthyroid increases your heart rate, makes you kind of tachycardic. You can have palpitations, irregular heart rhythms. Blood pressure could become increased. You could become super hypertensive. tachypnea, tremors, nervousness, anxiety. Basically, everything's kind of a lot of anxiety, a lot of temperature increase, fevers, sweating, hyperactive bowel sounds, cramps, diarrhea. Just the opposite of metabolism is sky high. The worsening cues of this is thyroid storm or toxic thyroid levels, basically causing not just tachycardia, but severe tachycardia over the 120s, severe hypertension, 120s, 110s, very high blood pressures. And those high blood pressures can cause hemorrhagic strokes, burst blood vessels in the brain, can cause the heart to just work too high. The high temperature can become problematic, and agitation, restless, delirium. So again, hyperthyroid doesn't usually go to the worsening cues, but you do want to look out for them. Again, the key assessments are just like hypothyroid. We're going to look at the heart rate, EKG, blood pressure, respirations, temperature. Expect them all to be elevated. The T3, T4 levels, and the TSS, thyroid stimulating levels, are higher. And the treatment for it is to remove the thyroid gland or get rid of the overactive thyroid gland. They can do that two ways. You can do radioactive iodine. You can do a thyroidectomy, which is the surgical removal of the thyroid gland. And so I did this as an actual procedure because it's a pretty common procedure, removing the thyroid for hyperthyroid. Again, if you don't make enough hormone, you give the hormone. If they're making too much and things are kind of out of whack, you got to treat the underlying cause, which is usually the overproductive thyroid. After the thyroid procedure, really, it is a procedure where you are doing a lot of incision and swelling in the neck area, so that's what we're really worried about. Also, the thyroidectomy can goof around with your calcium levels. And I think, let me go back to the picture. Oh, I don't have a picture. Oh, there they are. I have them on the parathyroid. But do you see these parathyroid glands here? They are sitting at the back of the thyroid gland. So when they remove the thyroid gland, they try to preserve a little bit of thyroid tissue with the parathyroid glands around it, because the parathyroid glands control our calcium levels. So that is why when you are getting thyroid surgery, you have a problem with your calcium levels, because the parathyroid is embedded in the thyroid gland. But we are not expecting tracheal swelling, laryngospasm, or stridor. That's too much swelling around that incision. Recommended to keep a tracheostomy set nearby. If there is so much swelling that your trachea becomes obstructed, you're not going to be able to get a tube down their trachea, so they would have to go in with a tracheostomy. So just in case of tracheal swelling post-procedure, they want you to keep a tracheostomy and oxygen equipment nearby. Airway is the most important thing to preserve. The patient could bleed, and of course bleeding in that area, they may have repeated clearings of the throat, because bleeding in that area is stimulating your esophagus, thinking that it's full when it's actually just a hematoma around the esophagus. But you're going to keep an eye for a hematoma or constant clearing of the throat. That could be a sign of bleeding. Look into that. They can go into thyroid storm in the first 12 hours after surgery, because the excess thyroid hormone that's released when they go and cut the thyroid gland can cause a post-operative thyroid storm that causes high blood pressure, tachycardia, and fever that they would symptom treat. And then, of course, we're going to be watching our calcium levels after a thyroidectomy, because they could damage the parathyroid gland. So if for some reason they remove the parathyroid gland or cut it, or it swells to the point where it's not working, you could have hypocalcemia. You could also have hypercalcemia if it's stimulated to secrete too much. So calcium levels are important post-thyroidectomy. And let's see, what do you teach about it? Mostly that you're going to have probably have your thyroid removed. If you are using radioactive iodine to kill off the thyroid, then ask about iodine shellfish allergies. and nutrition. They will, remember when you are hyperthyroid, everything's kind of revved up, including your metabolism for eating. They're also getting a lot of diarrhea, diaphoresis, a lot of fluid losses. So make sure that everything is kind of symptom controlled. We would also use maybe some blood pressure meds if it is high. But again, they're going to go in and take out. They're not going to spend a lot of time treating symptoms when the problem is the thyroid gland. They're going to remove it. If you are post-thyroid removal, you have removed the thyroid, and they will need lifelong replacement therapy. So if they've removed the thyroid because it was hyperactive, now it is gone and it is hypoactive, and it will need replacement therapy. So not while you're hyperthyroid, but after you've had the intervention, you will be hypothyroid. Avoiding weight gain in the adjustment period from hyperthyroid to normal thyroid levels. These patients go from being super metabolic to low metabolic. Weight gain is a big problem post-op thyroid removal or post-thyroid removal, and that they'll need to take their thyroid hormone replacement and stabilize that dose. If the parathyroid gland was removed or damaged during that thyroid removal, then they may need calcium supplements based on the lack of parathyroid gland. So, of course, I didn't put a huge thing about the parathyroid gland on there. I drew circles around them and just said that if you are hypoparathyroid, you are hypocalcemic. And if you are hyperparathyroid, it is hypercalcemic. So you can go in and insert your hypo and hypercalcemic slides here. I did not do that. So I'm going to let you take a little break, shut it off, pause it, and then we'll talk about adrenal gland. You've had enough here. You've had DI, you've had SIADH, you've had hyperthyroid with thyroid storm, and you've had hypothyroid with myxedema coma as the worsening cues, and parathyroid gland is calcium. Hypoparathyroid, low calcium, hyperparathyroid, high calcium. So we're going to move even lower now in the body to the adrenal gland, which is sits right on top of our little kidney, and it controls a couple of hormones. The cortex, it's actually two glands. The cortex on the outside is our cortisol and aldosterone. Oh, remember our little friend aldosterone from our renal lecture? Well, here's where aldosterone is made. This is where it is made. It's all stimulated by the renin-angiotensin-aldosterone cycle, but aldosterone is made in the cortex. Cortisol is also made in the cortex, and that is our long-term stress hormone. So we like to think of the adrenal gland as our stress gland, because in the inside, in the medulla, it makes epi and norepi. Epinephrine and norepinephrine are our flight and fight response. So when you get scared and you have that little jump to your heart, that is the flight-fight response. Those get you ready to flee, gives you all the tools you need to get going, increases your blood pressure, your heart rate, your blood flow to your muscles. And then if you have a long-term stress that you need to be living for a long time, cortisol takes over as our long-term stress hormone. So epinephrine and norepinephrine are our short-term flight-fight hormone, and cortisol is our long-term stress hormone. So I can guarantee everyone in nursing school has an elevated cortisol level right now because you are in a long-term stress situation. So I like to remember, and I think I put it on another slide, that our cortex makes our corticoid hormones. So your cortex makes your corticoid hormones. There's a glucocorticoid and a mineral corticoid. The mineral corticoid controls the minerals, sodium and potassium. Those are the minerals. And your glucocorticoids, those actually will control your blood sugar and your long-term stressors, that gives you things long-term, like helps you burn proteins and fat to continue making sugar. But I like the glucocorticoids will do something to your blood sugar. Your mineral corticoids will affect your minerals, and the minerals are sodium and potassium. So let's go look at these a little bit more. Here's your cortisol. And here's all the things it does. And you've probably given cortisol, you've probably given Stalumedrol, you've probably given steroids. These are all, your cortisol is all steroid hormone. So when you are giving steroids, you are doing all these things to your body. And we are using it for this one. We usually only give steroids for this one reason. We want to use cortisol's anti-inflammation properties. It shuts down your immune system because when you're in a long-term stress, you just don't have time to deal with it. You're busy trying to get your body food and resources for stress. So cortisol itself does reduce your ability to fight off infection, the anti-inflammation properties. So we use the steroids for that one property, but cortisol does a lot of other things. It helps increase your glucose, because when you're in a long-term stress, you're going to need more food. So it's like, here you go, I'm going to give you food for the struggle that you're going through. It helps detoxify things. It makes your memory, learning, sleep, mood a little bit sharper so that you can live through the stress. Helps you think a little bit. It's why you feel real good on steroids. It does cause your musculoskeletal, it will cause the bone to break down a little bit. It will cause your muscles to break down because you're trying to provide yourself with glucose. So it does a whole lot of things. Cortisol is really a stress hormone, and we give someone steroids. We're giving them steroids to do this one thing, but these are all, quote, side effects of steroids. They're not side effects. They're actual things that cortisol does. And when we give a steroid, you're going to get all these things as side effects. So let's look a little bit more at what cortisol and everything, what it's doing. Let's talk about first when we're not making enough. So when we are not making enough cortisol and aldosterone, our adrenal cortex hormones, it's called Addison's disease. Addison's disease is a lack of cortisol and a lack of aldosterone. I like to think of Addison's deficiency as adrenal deficiency, and you need to add cortex hormones. So we are lacking our cortisol and we're lacking our aldosterone. So aldosterone, as we remember from our renal lecture, is where aldosterone causes us to retain fluid and sodium and pee out potassium. And since we do not have aldosterone, we are not retaining fluid. We become a little bit orthostatic hypotensive, a little dry. We become hyponatremic because we are excreting water and sodium and holding on to potassium. That is what the aldosterone, it's the opposite of what aldosterone is supposed to do because we are lacking it. Aldosterone is supposed to retain fluid and sodium and excrete potassium. And when we are a lack of aldosterone, we excrete water and sodium and hold on to potassium. So Addison's disease has orthostatic hypotension, hyponatremia, and hyperkalemia. The lack of cortisol, remember this is a glucocorticoid, so you have a low blood sugar. You don't have enough of your cortisol, which will maintain your blood sugar. Weakness, fatigue, mood changes, irritability, depression. Remember, glucocorticoids make you feel good. They keep you in tip-top shape. They keep you smart and going during your stressful period. Anorexia, weight loss. cortisol is going to make us gain weight because during a stressful period, you want to make sure that you're not going to starve to death. So, hey, your body's just trying to, through nursing school, nurture you through stress. That's why you're gaining weight. But when you are not, when you don't have enough cortisol, then you have weight loss because you do not have the cortisol trying to beef you up for long-term stress. Nausea, vomiting, diarrhea, and hyperpigmentation also go along with a lack of cortisol. So when we think about our stress hormone, it's just trying to help us. Sometimes we get stressed when we don't need to have everything that, the stress hormone's doing for us. These are primal reflexes from back when you were a caveman and you were saving energy for during your stressful times were times of starvation. And so your cortisol holds on to every kind of food that you get. So when you are in high stress, cortisol is supposed to hold food for you and keep you all padded and fat for your long-term stress. And then it will also break down your bones and your muscles to provide glucose for you during your long-term stress. And it's supposed to keep you sharp. So when we are missing those things, we have weight loss, GI symptoms. You're not feeling as sharp, very fatigued, and low blood sugar. That is Addison's disease. You don't make enough glucocorticoids or mineralocorticoids, and you need them replaced. The worsening cues of Addison's crisis, well, if you have Addison's disease and you have an acute stress, a severe illness, or an acute surgery, something that's very stressful, and you don't have an adequate dose of steroid, or you have stopped your steroid placement, Addison's crisis is an extreme lack of aldosterone and cortisol, life-threatening hypotension, severe hypoglycemia, massive hyperkalemia. So basically all the things that we don't like about Addison's disease are getting worse. We don't like the hypotension, it's getting worse. We don't like hypoglycemia, but it's getting worse. We don't want hyponatremia and hyperkalemia, but they're getting worse. And you've got massive vomiting, diarrhea, and already got hypotension and dehydration. It's getting worse. So Addison's crisis is worsening conditions of Addison's disease. Addison's disease is adrenal deficiency, a lack of your cortex hormones, and you need to put those back. So the interventions are going to be giving yourself glucocorticoids and mineralocorticoids. You're going to be replacing these, usually just a PO dose to maintain yourself once you've been diagnosed. If you are in Addison's crisis, you can give high-dose hydrocortisone IM or IV to reverse that Addison's crisis. Patients must always know that corticosteroids should always be tapered, not stopped abruptly, and they need them to survive. So you're not going to have side effects of steroids when you're in Addison's disease because you're just taking enough steroids to make yourself normal. With Addison's disease, you have low blood pressure, low blood sugar, so you would treat those symptomatically. Hopefully, once you get your hormones replaced to the right level, you will replace your aldosterone and your cortisol. You should not have the lack of aldosterone problems. Your blood pressure should come up. Your hyperkalemia should resolve. Your hyponatremia should resolve with aldosterone replacement. And your cortisone replacement should maintain your blood sugar and maintain your weight. The causes are usually autoimmune against adrenal cortex, infections, some drugs, or if you've actually had an adrenalectomy, maybe you've had trauma to the kidney and they ended up taking the adrenal glands, then maybe you could have, a actual physical adrenal removal can cause Addison's disease. Adequate doses do not have side effects that relieves the hypoglycemia, GI, and mood symptoms, so make sure your patient knows that taking the steroids is not a bad thing. It's not like you're going to get amped up because you're just taking adequate doses that are going to make you normal. Too high of a dose, though, can send you into Cushing's syndrome, which we'll talk about next. And they may need, because we don't have our own body to tell us when we're in a long-term stress situation. If you are Addison's disease and you're in nursing school, or you're about to undergo surgery, or you're sick with a severe illness, you may need to increase your steroid dose to cover that time of stress. But do it with physician approval. So they're very close with their physician in management of this disease. And then aldosterone replacement, they should watch their urine output and their electrolyte levels, or have them watched by the physician, because the aldosterone replacement, if you give too much, then you will end up with fluid retention, hypokalemia, and hypernatremia, and adequate doses will not relieve the symptoms. So making sure they know why to take the glucocorticoid, the mineral corticoid, to continue taking it, to talk to the doctor before any changes in the doses, and to let the doc know about their symptoms of hyper or hypo. If you are getting fluid retained or you're getting dehydrated, they may need to fix their aldosterone dose. There's a little extra picture of your adrenal patient. The Cushing's patient is the patient that we think of with an overdose of steroids, the Cushy patient. There's Cushing's disease and Cushing's syndrome. They both cause the same symptoms. It is an excess of cortisol. So your body can make the excess of cortisol, or maybe we're giving you a lot of cortisol or glucocorticoid medications. If we're giving you medications, it's called Cushing's syndrome because your body didn't do it. We did it to you. So that's usually from high dose or long-term corticosteroid use. Cushing's syndrome. Cushing's disease is where our body is causing excess levels of cortisol. So it's either from the pituitary, because remember, one of our pituitary glands, the anterior pituitary, produces the ACTH, the adrenocorticopic, I can never say that right, corticotropic hormone, ACTH. So if your pituitary gland is secreting this ACTH, you're going to have high levels of cortisol in the body. Cancer tumors can produce ACTH, and then if you actually have a tumor on your adrenal cortex, it will secrete too much steroid and aldosterone. But we do separate, so when we talk about Addison's disease, that is a deficiency of the cortex. It's deficient in both aldosterone and cortisol. Cushing's disease is just cortisol. So if you just have increased pituitary ACTH, you'll have just Cushing's disease. It does not affect aldosterone. Cushing's is cortisol only, and then we have hyperaldosteronism. If you have an adrenal cortex tumor, you can have Cushing's and hyperaldosteronism, but Cushing's means cortisol only. So Cushing's goes with cortisol, and it's an excess of cortisol. The cues of it are what we think of the signs, the signs and symptoms, or the side effects of glucocorticoids. It's not really a side effect of glucocorticoids. It's just because we're giving too much cortisol to the body. Because it's a glucocorticoid, cortisol is, you get hyperglycemia. So too much cortisol makes you hyperglycemic. You're giving yourself too much sugar. You're breaking down your bones and your muscles to make this sugar. Hyperglycemia is a side effect of cortisol. The stress hormone's just trying to do a good job. Cortisol's just trying to provide you with some sugar, but when we have too much of it, it's just doing a little bit too much. Your white blood cell count, you would want to watch it because you're susceptible to infection. Because remember what cortisol does? It kind of shuts down your immune system. It kind of decreases your white blood cell production. It kind of says we don't really have time for that right now. We're under a stress thing going on. But when we give ourselves too much cortisol, or body produces too much cortisol, we have a high susceptibility to infection. Increased blood pressure comes with, usually with aldosteronism, but increased weight because cortisol's trying to hold on to some calories for you. You're going through a long-term stress, or you're giving yourself stress hormone, or you're creating stress hormone, increased weight. The fatty tissue deposits are found in the belly, the upper back, and in the face. Neurological, you can feel great It's supposed to make you sharp, but too much of it can cause mood swings, some anxiety, some irritability. And the skin, it does not do good for the skin. High levels of cortisol cause delayed healing because, again, we ain't nobody got time for that. We're under stress. Delayed healing of wounds, it shuts that part down. Muscle atrophy, weakness, protein depletion because it's using all that to make sugar. Because it thinks it's doing the right thing. It's trying to fatten you up for the winter, but it's doing a little bit too much when you have too much cortisol. Thins the skin, easy bruising, brittle bones, weak tendons. Remember, it's leaching all of those nutrients and muscles in order to get you fat and full for the winter. Thicker body hair and facial hair, again, when you have a lot of stress. Remember, this is a primitive response that most stress, up until the past past 100 years, most of our stress was due to starvation. So these are things to counter starvation, really, is what cortisol's role in the body is. A long-term stress was considered by the body to be starvation, but now we have long-term stress that's not involved with starvation, but our body's treating us as if we're starving. So long-term excess cortisol, excess stress, or taking too much of a glucocorticoid for the purpose of shutting down our immune system or inflammation actually causes all these things along the side. So it's really kind of a body system function that works when it's supposed to do what it's supposed to do. If you are starving to death, it's a great tool to have cortisol released. It protects you from starving to death by allowing you to break down and get nutrients other ways. But if you are just in nursing school and stressed out mentally, you still get all these effects of it. And then if you take steroids for an autoimmune response, or we're trying to shut down the immune system, you end up getting all of these extra things as a side effect. Worsening cues of Cushing's syndrome are recurrent infections, increased white blood cells without a fever, your immune system can't mount a fever, severe hyperglycemia, severe hypertension. So since most of this is blood sugar related, we will be watching blood sugar. Most Cushing's disease is high blood sugar. Watch that white blood cell count. Look for signs of infection. You might not see your signs of infection. You might not see a fever. Your immune system is kind of shut down, whether we did that to you or because you have excess cortisol, it's happening. Watch the blood pressure, the weight, appetite is going to be higher because, again, cortisol makes you kind of fatten up for the winter. The skin gets thin, fragile, the bones get fragile, the muscles get wasted. Those are the signs of Cushing disease. So what do we do if you have Cushing's disease? If you have Cushing's disease due to a tumor or too much ACTH tumor, it's tumor removal. If it is drug-induced Cushing's syndrome because we gave too much corticosteroids, then the dose must be tapered gradually. Hopefully you could go to a lower dose or alternate day regimens or switch to something other than a steroid. Steroids are not mainstays in our autoimmune response long-term anymore because of Cushing's syndrome. Monitor the blood sugar. The hyperglycemia may need extra insulin or oral diabetic medications to keep it under control. Strict infection control, antibiotics, blood pressure reduction, and of course, if your bones and muscles are wasting, then definitely a fall risk. And then monitor skin and wounds because they are not healing well with Cushing's disease or syndrome. So if we did it with steroid drugs or glucocorticoid drugs, then we need to change to something else to suppress our immune system. Long-term steroids are no longer in favor. They used to treat asthma and a lot of autoimmune diseases with steroids long-term, but the high incidence of Cushing's syndrome has made that a less palatable choice. So we've developed other medicines for immune suppression. And if it's a tumor, those will be removed. Hopefully once they get their hormone levels under control, they will lose weight, physical changes, emotional ability will get under control, make sure they're monitoring their blood pressure, their weight, and doing follow-up and lab work. calcium supplements for brittle bones to get those bones beefed back up. We leached out all the calcium during our cortisol time. And then hyperaldosteronism is secretion of too much aldosterone. Could be due to increased renin secreting tumors. Renal disease causes increased inappropriate renin. We could have a tumor of your adrenal gland. Anyway, if you have too much aldosterone, you're going to have too much fluid retention, hypernatremia, and hypokalemia, because the process, what aldosterone does is retain fluid and sodium and excretes potassium. So the weight would be increased. Your lung sounds are fluid overloaded. This is just basically fluid overload. Hyperaldosteronism is fluid overload. We treat hyperaldosterone by getting rid of the tumor. If it's not a tumor, if it's fluid retention due to renal disease, then you will take potassium-sparing diuretics. We want to get rid of fluid, but not potassium, because potassium's already gone. When you have hyperaldosteronism, you hold fluid and sodium, but excrete potassium. So we would want to get rid of fluid and sodium, but keep potassium. We're already low on potassium. So potassium-sparing diuretics, potassium supplements, calcium channel blockers can decrease blood pressure without getting rid of extra fluid. Sodium restrictions, because we are retaining too much sodium already. So it depends on the cause. If you can get rid of the cause with an adrenalectomy or a nephrectomy to remove renin-secreting tumors, then that will solve the problem. If you cannot solve the problem because it's renal disease and their hyperaldosteronism is from renin secretion, or inappropriate renin secretion from your kidneys, then you will symptom treat it with potassium-sparing diuretics, potassium supplements, and sodium restrictions. All right, so last one on this lecture is pheochromocytoma, which is just so much fun to say. And it is a tumor of the adrenal medulla that makes you secrete too much epi and norepi. So the patient gets spontaneous and intermittent bursts of epi. The spells can happen spontaneously, or they could be triggered by stress or severe illness. Some trigger foods or tyramine foods, stimulants like caffeine. But anyway, the symptoms of you getting a jolt of epi or norepi is a jolt of your fight-flight. So instead of just regular high blood pressure, you get severely high blood pressure. It's an inappropriate oversecretion of epi or norepinephrine. Severe headache is due to the high blood pressure, severe tachycardia, sweating, tremors, shortness of breath, anxiety or sense of doom. Can you imagine if you've ever had a burst of being scared, that burst happening for 10 minutes, you would get high anxiety. The worsening cues of this is not being able to control the blood pressure, or the tachycardia causing hemorrhagic stroke, cardiac failure, or respiratory alkalosis from the severe tachypnea that you might have. We actually had a patient in clinical that had this. They were giving tons and tons and tons. They were giving every blood pressure med they could think of, metoprolol, cardizem. They were giving calcium channel blockers. They were giving beta blockers. Nothing would touch the blood pressure. Didn't even bring it down. And the patient was having massive headaches. The room was dark. They were tachycardic, high blood pressure, and it turned out she had a pheochromocytoma. The only time in 20-something years I saw it was 3 years ago at clinical. So I had a pheochromocytoma that they found on a CT scan. They found a tumor of the adrenal medulla. What they're going to do is they're going to give you beta blockers, alpha blockers, and again, these are high doses because you're overriding a natural body stimulant. So we have to block that stimulation with alpha blockers and beta blockers because that's what epi and norepi do, is they are alpha and beta stimulants. Alpha blockers, alpha stimulation is going to cause vasoconstriction. Beta stimulation is going to cause increased blood pressure, increased heart rate, and increased bronchodilation. So when we block those things, you're going to get vasodilation, a slower heart rate, and some bronchoconstriction. So anyway, you would want to watch these patients very closely. A patient with a pheochromocytoma is usually in the intensive care unit to be monitored and give these meds, because once those beta blockers and alpha blockers hit, and you're giving such high doses of beta blockers, I was even nervous for this poor woman. I think they ended up giving like 200 of metoprolol and something crazy of deltiazem, which is a calcium channel blocker. They were giving so many blood pressure meds that I was scared this patient was going to be in the toilet when they finally came out of their episode, and it is pretty delicate balance. So I just wanted to point out what a pheochromocytoma is. It's going to be severe hypertension, but you are symptom treating it until you can take care of the surgery to remove the tumor that is secreting the epi and the norepi. It is symptom treatment, but it is very closely monitored. And we just want to keep the patient from having the worsening cues where the blood pressure goes so high it causes a hemorrhagic stroke from burst blood vessels in the brain, and then the heart working so hard and getting tachycardic and high blood pressure that you can go into cardiac failure. So usually a pretty critical patient with a pheochromocytoma. But I love saying that word. So that was your endocrine lecture. Let me know if you have any questions, concerns, or problems, and I will see you in the hematology lecture.